much for being here. Do we have any cases? We always start off with our cases, even before we do introductions. Kind of set our agenda up.
Dr. Keith, Dr. Cole, Glenda, any cases this morning that you all want to discuss? Feel free to take yourself off mute or write into the chat box, please.
Okay. Well, if anything comes up, just feel free to keep it interactive and jump on in. To my left, your right, Dr. Lewandowski. He's a clinical psychologist, pain specialist, and one of the thought leaders here in the community. And to my right, your left, Dr. Patterson, another thought leader, pain specialist. And you we're at Nevada Advanced Pain Specialist, right? Okay, so I'm Paul, I'm a licensed alcohol and drug counselor, and today we are talking about diagnosing opioid use disorder and referring. So, opioid use disorder, what do we have? 72,000 people who have overdosed last year. So this is more than a crisis, it's like an epidemic. So there's something to this. There's something to the overdoses that need to be exploring. And so we look at addiction. Nobody starts off when they're in 5th grade or 6th grade and says, you know what, I'm going to be an addict when I grow up. This is what I want to become. Something happens to somebody where it turns them psychologically and physiologically into a relationship with a substance that takes over their life. So when we look at NIDA's definition, it's a chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. So the person's doing the same thing over and over again and having a lot of negative consequences in their life. It's all right, that looks good on paper, but it really doesn't mean what this person is going through. So I'm trying to figure out what's the compulsion, how to explain the compulsion. Well, imagine if I said today, I'm taking away all of your responsibility. You don't have anything to do today. And I'm also going to give you a pocket full of cash, so you can do anything you want. Now, just think about it for a second. Where did you go? What would you do with that freedom and the financial ability to do whatever you wanted? Did you feel kind of excited, a little bit euphoric, kind of like happy? Now imagine that times 100. And imagine that feeling consistently throughout your day, every single waking moment. And imagine the opposite of that is also true. If you're not getting that feeling, you're also getting really bad withdrawal symptoms. So the worst flu that you could ever imagine. That's kind of what people in addiction are going through. Also with addiction, when we get into slamming or smoking, whatever they're doing, if we're looking at heroin, which is just morphine, when people smoke it, they lose 75% of the drug to the atmosphere. When they slam it, they get it all. If you're looking at $10 to $15 per baggie and you're slamming it, you get it all, then okay, you have about 4 to 6 hours before you have to get that next hit. Now you can see how this cycle goes. If they're getting oxys out on the street, that's about $1 a milligram. So an 80 will cost you 80. So we can see where kind of the addiction kind of takes on a life of its own. So it's not considered a specific diagnosis in the 5th edition of the DSM. It's kind of the go-to. The DSM-5 is the go-to for clinicians. It contains all the descriptions and symptoms of mental disorders by the APA. So what's the DSM-5? This is what we use to set up the criteria to recognize if somebody has dependence issues. So this all occurs within a 12-month period. If the person has 2 to 3 of these, there's 11 of them, I'm just showing you the first 5. If the person has 2 to 3 of these, it's considered mild substance use disorder. The substance you can switch out to opioids, alcohol, benzos, you can switch it out to anything, but it's mild substance use disorder. If they have 4 to 5 of the criteria, it's moderate. If they have 6 or more, it's considered severe. So when I'm looking at someone and I'm doing an evaluation, I'm looking at their relationship with their substance. And if we look over the first few of these, we're looking at how much time do they spend in their relationship with their substance of choice. Keep in mind, once we get done or identify that this substance is causing a substantial amount of problems in their life and we take that out, then we also have their secondary substance of choice that they might go into. So I had a lady who was on benzos for 20 years and she was able to stop. No problem. No problem? 20 years? Really? Okay. Where's that secondary? She was drinking a couple bottles of wine before she went to bed. So she just substituted one for the other. Another thing we have to look for is behaviors. So say we take the substance out, say they like to drink a lot. Well, what about gambling? What about, or if they stop smoking meth? Meth is taken over their life. Well, now they're drinking 5 Red Bulls and smoking a lot of cigarettes in the same place that they used to use their meth before. So we're looking at different substances. We're also looking at different behaviors: shopping, exercise, porn, gaming, gambling, all of the behaviors that somebody could pick up to substitute to get that dopamine release, to get that escape that we were talking about earlier. So we look at this relationship, and then we have to look at the whole person to find out what are the potential problems as well as the problems that are hitting us in the face right now. So the substance is taken in larger amounts or over a longer period than was intended. They tried to stop and they just couldn't stop. They spend a lot of time either being high or recovering from being high or chasing being high. Craving, this is different from DSM-4. DSM-4 had incarceration. So they took that out and they put in craving, the strong desire or urge. And then we look at the relationship and what it's doing to their major role obligations at work, school, or home. And then we look at their relationship, how it's impacting their societal obligations. So they continue to use the substance despite having persistent or recurrent social or interpersonal problems. Okay, well, a lot of times I get somebody who says, no, I'm not drinking anymore. Well, okay, let's look at when you were drinking. But I stopped. I am not drinking anymore. Okay, well, this is not a projection of future events. This is trying to capture how the substance impacted you previously. So if you've had 6 DUIs and you've been incarcerated for 15 years, all due to alcohol-related problems, you probably have an issue with alcohol. So we want to make sure that we capture the complete picture of where that person is and the potential problems that the substance can have if they go back to using the substance. Because substance use, especially with opioids, is progressive, and it's permanent, and it's predictable. and it's also preventable. 4 Ps. Okay, so if we're looking at the predictable, if somebody goes back to using, if they're using a gram of heroin out on the street, and they stop using for a year, and then they go back to using, they're not going back to smoking. They're going back to shooting that gram of heroin. Here's the problem. They've screwed up their tolerance with that year of not using. Say it took them 10 years to build up to that gram. Their body became used to it. Psychologically, they haven't forgotten it. If they're going to go back, they're thinking in their mind, I'm going back and I'm going to party, and this is where I left last time. So I'm going to go back and use it. I was using a gram. I'm going to use a gram because it's a big party. Boom, here I go. Now we have the overdose because the respiratory system is just closed down. Keep in mind the same part of the brain that controls the respiratory controls our breathing or our heartbeat as well. So it's all that's connected. Important social, occupational, or recreational activities are given up or reduced. So they'd rather get high or they'd rather use than go to the birthday party. And then they feel really remorseful when they miss that birthday party. So what do they do to avoid that remorseful feeling? Use again. Do they drink, drive? Do they use and drive? Number 9 is, that's an easy one. You can just ask them, do you know that using this substance is bad for you? Tolerance, where you need more of the drug to get the same effects, or the effects are diminished with the same amount of the drug. And then withdrawal, there's all kinds of withdrawal symptoms. So 2 or more of those, mild, 4 to 5, moderate, 6 or more, severe. And the idea here is just to create a baseline so that we can then start. And the idea is for these criteria to go down. Because once the person has stopped their relationship with the substance, the relationship with the family is going to go up. Their relationship in their employment is going to go up. Their relationship with themselves, their health is going to go up. So everything goes up, just like everything circles the drain when they're really deep into their addiction. So a couple of different things with the DSM-4 and DSM-5. Remission, this is important. Some people say first day is the most difficult day. I think it's around the 3rd or 4th day, because with the first day of not using, the person is usually get that incomprehensible demoralization, that deep remorse, where you get that actual sweet spot where they're motivated by fear or whatever to come and actually get some help. But on the 3rd or 4th day, they're figuring out, hey, you know what? I didn't die from it. And I'm feeling pretty good. And I've slept for a little bit. So life is not as bad as I thought it was. Or now that I'm sober, life is worse than I thought it was. So it's that 3rd or 4th day that I think we really need to surround people with a lot of love there and support. If we're looking at early remission, that's defined of at least 3, but less than 12 months. After the, and that's without any of the criteria except craving. Craving can go on for years. Like I talked about benzos before. So that takes months to get people off of. It can take a year to get somebody off of a benzo. And the idea of the cravings is that's just your relationship wanting you back. That's, you know, we've trained our brains to think that way. Of course, we're going to have cravings, desires, wants. That's where the help comes in. That's where treatment comes in. When we're talking about treatment, every one of these levels of care indicate different settings, staff, services, and discharge criteria. So when we look at level 4, that's medically managed intensive inpatient treatment. that's a little bit more than the residential treatment. You can mix and match them. But the idea there is the person's detoxing. They need a doctor 24/7 and medical care to make sure that they're managed and get all their systems back in order. Residential or inpatient treatment, that's where you usually hear about it, the 28-day program. It's where we pick the person up, put them in, teach them yoga, do all kinds of teaching, group settings, counseling. There's psychology available, psychiatry, biometrics. You're looking at their whole world, treating or feeding them good, giving them good information, teaching them how to do their chores. They're getting up in the morning and they have a strict schedule. It's residential treatment. Then what happens is we take that person out of that 28-day cocoon and we drop them right back into that environment that they were in before where nothing has changed and say, hold it, you're supposed to be better. Why aren't you better? And we really set them up to fail if we just kind of let them go there. Successful residential treatment is considered about a year of sobriety after they discharge. Now, if you want to get it more success, you go into level 2. So you take that residential treatment, that 28-day, 24-hour monitoring and structure, then you go to IOP. IOP can be used 2 different ways. You can use it from the person who says, or the insurance company who says, how do you know they're available for residential treatment? They haven't failed IOP. You get that argument a lot because residential is expensive, IOP is a lot less expensive. Or you can use it the other way where the person, you don't know if they're ready for outpatient, so you can get them into IOP. IOP is 3 sessions a week, 3-hour sessions for about 3 months. It also has individual counseling and it has a family or support person. So the idea is you get the 24-hour monitoring and structure, and now you're going down to 9 hours. And with that 9 hours, the rest of the time they're working and they're spending time with their family and they're testing things out while still be accountable in that group setting. Then we have outpatient treatment, which goes down even further, and that's 2 to 3 months. And that's 2 sessions a week for 3 hours a session with the support person and individual counseling. And then finally, intervention, 0.5, that's individual counseling sessions. So see how it titrates down. When it's going down this way, they're getting their coping skills and the cravings are becoming less and less intense, and they're able to test out their environment that they're supposed to be working in and being productive community members in.
Paul, go back one. Is there one area where patients are more prone to relapse? Is it going from level 3 to level 2? I mean, that would be my guess off the top of my head.
You know what, relapse, that's such a good question. I'll go to it right now. When we're looking at somebody in their relationship with their substance, you don't know what's going to trigger them, and sometimes they don't know what's going to trigger them. The cravings come in really odd ways. Sometimes it can be a big, loud voice inside their head saying, you gotta use me now. Sometimes it can be just a small little, hey, I'm over here, don't forget me. Sometimes they're on autopilot and they find themselves in the liquor store. You don't know. When we're looking at the stages of change, that's why this is it's kind of complicated. And that's why when I do an evaluation, I do a complete biopsychosocial evaluation. It takes 2.5 hours to get an idea of where this person is by putting all this stuff together. And one of the things is I look at the stages of change. So pre-contemplation, where the person thinks, I don't have a problem, or yeah, I have a problem, it's you. Get off my butt. I'm going to use. Everybody else uses, it's cool, I'm good. Contemplation. That's where, you know what, every time I get into trouble, this substance is involved. I'm contemplating, maybe this is not positive. Preparation. I know I have an issue. I know I'm going to get better. I know I'm going to see the counselor. I know I'm going to get a job. I know I'm going to get that good relationship. I know I'm going to have a healthy life tomorrow. That's the Barstool one. Barstool fantasy chit chat, cocktail hour BS stuff. Action, that's when they're actually doing it. So I'm trying to get people into action.
Yeah.
And then maintenance is, that's a few years down the road where they wouldn't take it if you offered it to them. And here's the stage of change that nobody likes to talk about that you just brought up brilliantly and courageously. Relapse, it's a stage of change. It's something that we have to look at. And we can use that relapse as actually a really good educational experience, especially if we find out how they felt when they were relapsing. Because they're thinking about it. Relapse doesn't happen when they pick up and drink. That's the end of it. Relapse happens way back here with the thought process. When they stop using their tools, when they stop going to counseling, when they stop doing all the things that they need to do, and they let that little voice take over, and then all of a sudden, they get to this point where it's right there, and they get the I deserve it, or the F it's, or the who cares, or the PLOM, it's a technical term, poor little old me. And so there's all kinds of thought processes that go into actually using, and that's relapse. So we can learn a lot from the relapse. When we're looking at this, where were we? Back here.
Do they even recognize what the trigger is that makes them relapse? Or
Sometimes. That's wonderful. Sometimes they don't, and so we have to go digging, figure out what made them. Okay. Yeah, was it? And it could be the stupidest thing in their mind. No, but all of this manifests in real life negative consequences, so we have to look at everything. It's real exploratory, trying to figure out where that person is, where their mindset is. And you know, if they've been drinking for 10 or 20 years or using for 5 or 10 years, or you know, if they're a mess for 2 or 3 weeks, there's a lot of exploring to do. There's a lot of stuff that we have to get into to figure out where this person is. Dimensions. So part of the diagnosis is you have to look at the dimensions, and so you want to know their potential for intoxication or withdrawal. When's the last time you used? That's a pretty good indicator. What have you used? How much have you used? Biomedical conditions. Well, do you have anything, liver conditions? Have you broken any bones? All of your medical. Emotional, behavioral, and how are you feeling? Anxious? Depressed? Well, once people are in their relationship with their substance, there's a lot of times where it's substance-induced depressing disorder. You take the substance out, you surround them with some family and laughter and good food and love, and actually, like, laughter is a big one, because this is a very dark, sad time when people are using. You get that laughter back, and all of a sudden, their depression goes away, or at least is less. Same thing with anxiety. There's the package deal with substance use brings all kinds of things. Treatment acceptance or resistance. Are they willing to go to treatment, or is that the last thing that they have in their mind? Relapse or continued use potential. What type of drug have they been using? How long have they been using? What are their coping skills like? What's their education like? Have they been in treatment before? How many relapses have they had? What's their legal situations? What's their family situations? That's a whole world in itself. And then recovery environment. Where are you going back to? What's your support system look like? What have you been told all your life? How's school? How's your potential? How's your life? What's your hope for the future? So this rating system is low, moderate, or high. So see how we're putting together this rubrics cube? We got the diagnosis that's taking in all of these different things. Then we have stages of recovery. So now we're looking at different therapies that we're going to use. We're starting to get an idea of, okay, if this person is in early recovery, they're fragile. So we want to focus on abstinence, then on staying sober. So abstinence, when we're doing that, because of high relapse potential, you're using motivational interviewing or that type of interviewing. It's that type of therapy where you're talking to them and they're drawing out their reasons for staying sober. If you slam them with CBT or just go to AA meetings, then that's really not going to work. This is you got a brand new baby. You want to take them like brand new baby steps. Middle, fairly secure with abstinence. This is about a year, can last a lifetime. Now we're into CBT. Now we're into different thought processes. Now we've experimented with quite a few things. It takes a year. It takes experiencing all the seasons. You know, when somebody says that they get a sponsor at AA, it's like, great, tell me about your sponsor. How much sobriety do they have? I'm not doing that so I can judge them. I'm asking because I want to know that that sponsor has gone through all of the life's challenges of happy things, sad things, relationship problems, all kinds of things that only life can bring, and stayed sober. Also want to make sure that that person is trustworthy and reliable, because we're going to be telling this person some pretty deep things that we want to keep safe. And so you want to make sure that that person is trustworthy. One way to tell if the person's trustworthy is, are they talking about other people to you? Well, then chances are they're talking about you to other people. Another thing you want to make sure is with the sponsor, the person doesn't have 20 sponsees. And they're always available, because this stuff doesn't happen 9 to 5. You want to be able to make sure that at 7, 8, 9 weird hours of the night, that person is available to check you out. And the reason that you want to talk to them is because when you expose something, when you talk to people about your cravings, when you talk to another human being about a feeling inside, when you expose that feeling to light, it loses its power and you regain your power. And then the other person doesn't necessarily even have to give you the best advice. The person there is most beneficial just to listen sometimes.
Yeah, how do people become sponsors? Do they volunteer?
Yeah, each one teach one. Over at AA meetings, and one of the things about AA is you'll find I got wrapped up into AA because I do a lot of work with the court system, and it's free and it's available and it shows some good results, and so why not? So I wonder what's going on over here. So with the sponsors, they ask who wants to be a sponsor or who's available to be a sponsor. And so people in their meeting, they raise their hand, and then the new people who come in can go up to them and ask them.
Does the sponsor going to be, in the stages of recovery at a latent maintenance, or where is the sponsor at in the recovery?
Hopefully, they have years of sobriety. I'm talking more than 2.
Okay.
They've gone through the 12 steps themselves. They're not your best friend. Do not use a spouse. as your sponsor.
You
You want somebody who's outside, yep. And it's kind of like a peer support, but with the 12 steps, and I can review the 12 steps. 12 steps are about change. It's about personal life change. If you look at the 12 steps, the first step, we admitted we were powerless over alcohol, that our lives had become unmanageable. Alcohol, that's the last time and the first time that alcohol is mentioned in the 12 steps. The rest, the 11 and a half steps, are set up for the person's self-exploration so that they can incorporate change into their life by doing a thorough inventory and then sharing that inventory with somebody, the sponsor, and then letting that go and then making amends with people that they've hurt while they were using. And amends do not mean groveling or saying, I'm sorry. Time for that chit chat BS is over. It's to say, I think I hurt you when I was using. How can I make our relationship good again? And then give it to the other person. Many times the other person will say, we're good. Just stay sober. Be who you are. If you stole $10, then you pay back $10. It's making yourself, it's bringing yourself back to your core beliefs and values and making amends, making everything right. Then that's step 9. So I'm going through a whole bunch of them. And when they talk about spirituality, they're talking about your conception of your higher power. They're not talking about selling a religion or a cult or anything like that. You decide your higher power, and that's the one you go with. Then, after you've made these changes, and you're good with yourself, going forward, if you do something that needs to have an amend made, you make that amend immediately. You hurt somebody, or you say something that's not nice, or you do something that's not consistent with your core beliefs and values, you make that amend immediately so you don't have this big laundry list and that big bag of remorse that you're carrying around all over the place. Then your job is to teach some new person who came in who was struggling just like you were in the very beginning and help them make the changes and give to them what was freely given to you. That's why it works. It's a spiritual program brought on by people.
So they would never let somebody who's in the early stages of recovery be a mentor, I'm assuming. When they're fragile, I mean, it seems like they'd have a hard time being a supportive or a rock for somebody else who's also in the early stages.
It's not recommended, and all of these are suggestions. And good Lord, you can see the catastrophe that could cause. And that's why you want somebody. That's why it's so important to get somebody who's had a couple of years and to stick around the core group. What they say is you stay in the core group, because what happens to a herd, to those little ones that go out on their own? They're the ones that get picked off.
Correct.
So you stay in that core group, and they'll lead you in a good, healthy way.
So does the counselor for AA, the head person who's running the sessions, if they say, is anybody available, and somebody raises their hand, I mean, will they say, I don't think you're ready yet, you shouldn't be a mentor to this person, or?
Nope. There's no rules, there's suggestions. And if they sign off on a court documentation, that's a courtesy to the court. This is run by people whose only requirement to be in this meeting is the desire to stay sober. Okay. So it's peer support. And you know what? Without the hierarchy, without the rules, regulations, power, political, money, none of that stuff is, when they do what's called a seventh tradition, that's collecting money, that's so that they can pay rent, so that they can have people come in or buy chips. but nobody runs that.
Yeah.
And that's why I think one of the reasons that it's so successful. It's not, that's a great question. It's not ruled by politics or money or any of that stuff. It's just pure the desire to stay pure and sober. And where two or more people get together, you can have a meeting. So if you're in an airport and you need a meeting, you can have the person announce, Friends of Bill W, come on over to Concourse C on whatever gate. And you could have a meeting right there. So it's powerful, it works. If they understand. And another thing is you want to make them understand that it's not just a bunch of old people telling their war stories. They're sharing their experiences, strength, and hope so that you can learn from them and you might not have to go through all the pain that they've gone through.
Let's open it up real quick, see if anybody has any questions on this, on the 12 steps or AA or anything like that. Feel free to take yourself off mute, write in on the chat. We'd love to hear from you.
Okay, so when we talk to the client, we're doing screenings, assessments, diagnosis, and you want to keep all of these questions consistent and make them thorough so that you can help get a snapshot of where the client is and the areas of his or her life to treat. Again, we're looking at treating the whole person. So let's talk about referrals a little bit. So when I talk to people about what I do, they're like, oh, well, you must have been drinking or using a lot, and that's why you're in this job. So, well, what? The reason I really like being a licensed alcohol and drug counselor is that I've seen people die from using substances. I've seen families destroyed from using substances. I was so curious about what goes through a person's mind that they would actually do this, because if you're looking at somebody doing this, it's not poetic or romantic or anything. It's like, whoa, look at what you're doing to yourself and how you're hurting yourself. You're killing yourself and hurting everybody who cares for you. And the closer they are to you, the more you're hurting them. What the hell? What are you thinking? What I like about being a licensed alcohol and drug counselor was, okay, so how do I get people off of this stuff? It was all about me when I started this off, because I was volunteering over at a transition house where it was a bunch of guys who were coming out of prison and they're in town and they're trying to transition into society, and it's like, how can I do this? How can I give you the magic words? And you hang on to me and I'll keep you sober. You know, here's my cape. So when I started getting into this, it's like, whoa, I really don't know anything about what's going on here. Actually, I'm going to do more harm than good if I keep on going the way I am. So that's why I went to school to learn about this stuff. And then when I found out about this was my perception of getting into this. The only thing that was right about it was, yeah, these people are hurt and they need help. But getting the substance out of them is the smallest amount of stuff that I do. It's called detox. That takes a week, maybe 10 days, depending on the drug. So after 4,000 hours, well, graduate school, get your master's degree, 4,000 hours, then you are qualified to sit for the oral boards and the exam, the written exam. Then you can test out for the license. Then the state has to do the background check, and you have to pay a lot of money, and then they can give you the license. So in that, I also worked at residential treatment, intensive outpatient treatment, individual counseling, group sessions, and healthcare professional track, as well as a nursing track. And so when I'm looking at a licensed alcohol and drug counselor, that's all I've done. Now, when I say all I've done, that means that we've worked with families, because the individual who's impacted with substance use, guess who else is impacted? Their families. And the families, one of the biggest reasons that a person will get back into sobriety. So we do a lot of work with families. We do a lot of work with people, relationships. We do a lot of work with their relationship with themselves. We do a lot of work with the substance use induced depression, anxiety, all of that other stuff. And then self-esteem, anger, remorse, all of the stuff that comes with this. So when I first started into this, this started as really small. And then I asked people who are qualified, air quote, big air quote, qualified, to take care of somebody who's struggling with substance use. And they've had 2 classes where they say, well, where's the book that I can read to get into this? This is life and death, folks. The reason that I got into this is because I wanted to help people. And the further along I got into it, the more I recognized this is life and death. This is no joke. And so, but then there's a point where my scope runs out. And you know what? Frankly, I don't want to go out of my scope. So I have to know exactly what I can do, what I'm qualified to do, where my scope is, and then I transfer that person or refer that person gently, lovingly, in a team approach to somebody else to take care of other things, because I got a lot of people who need my work in this area. So that's kind of what I do. If you're going to add a licensed alcohol and drug counselor to your team, find out where they were educated, find out about how much experience they have, find out about their philosophy, find out about their success rate. They'll be able to tell you some success stories and some not so successful stories, and find out how they handled those, because the not success stories are not success stories today. You got to keep your door open. You have to keep that available for people who need you, because you never know when they're going to get it. I had this one guy who was on heroin, 14 treatments. We were ready to throw up our hands after the 3rd one, but he's running a clinic now, and I don't let him forget that. Okay, so clinical psychologist. Mike, what does a clinical psychologist do?
That's a great question. You know, psychologists, you can kind of break it up into different categories. You've got counseling psychologists, and they maybe deal more with a healthy person, healthy individual. Clinical psychology, we deal more with kind of mental health problems. And in my case, people with kind of a chronic pain condition. And I'm always asked, what's the difference between a psychologist and a psychiatrist? And I tell them jokingly, it's about $50 an hour. You know, we've got a psychiatrist here reviewing this, so very jump in if you want. But you know, psychiatrists go to medical school; they're physicians. They focus on pharmacology and other things. But as a psychologist, I don't have an MD. I don't choose to write scripts, although there are some subcategories of some places where psychologists have gotten training to do medication management. Most of us don't. So that's kind of the basic, you know, initial differences. So I have a PhD, which is actually an older conferred degree than MD. I'd like to always point that out. But I think, you know, when we work in conjunction with you know, our psychiatric and medical colleagues, it's the best that we can provide,
What-
especially for people with persistent pain.
Well, what's the difference between clinical psychologist and psychologist, and how would people refer to you? What would they look for to refer to you, and then how would you refer the person back to the referral?
So the word clinical is an interesting word. It suggests kind of in the trenches, but literally the state of Nevada does not, I'm not licensed as a clinical psychologist. The word clinical is not in it. I'm licensed as a psychologist. That's kind of a word we use to maybe clarify in greater detail what we do. But psychologist, there's no license for a clinical psychologist. It's licensed for the psychologist. And many of my colleagues they have a PhD program where the emphasis is on research and scientific exploration. There are PsyD programs, which is more clinically based. So even under the heading of psychologist, there's many different kind of degrees.
Okay.
And as far as a referral,
Yeah. What would a doctor look for to say, you know what, I need to add Dr. Lewandowski to my team, and I know what to expect, and then I'm going to bring this person back after Dr. Lewandowski is taken care of?
I'd say the biggest issue is the presenting problem. If it's a pain management issue, very appropriate to get a pain psychologist. Many people, though, have other health-related problems. Sleep's a big issue. People have insomnia. So
Yeah.
There's specialists amongst clinical psychologists that practice. Behavioral medicine is kind of the category. Health psychology. So you've got insomnia, you've got sleep issues, you've got pain management,
Okay.
alcohol focus too. So
Yeah.
it's across the board based on, I think, the presenting problem of the patient.
Okay.
So.
Any questions for Dr. Lewandowski? All right, Dr. Patterson.
So, a pain physician, it's kind of changed over the years. And what I mean by that, it's a newer subspecialty that's been recognized. So prior to 2004, anybody who had a special interest in pain could sit and take an exam, and if they passed it, could say they were board certified in pain management. After 2004, in order to become a pain specialist, you have to do a one-year fellowship. And eventually, I think that's going to change where it's going to become its own residency program eventually. So currently, now, in order to become a pain specialist, you have to, go to medical school, you have to finish an internship, and then do a residency. Typically, people who get involved in pain, majority of the time, they're usually an anesthesiologist. That's majority of them. The second biggest group that get into it are physical medicine rehabilitation physicians, which is what I am. And then you have a smaller percentage that are usually a neurologist, maybe a primary care, finished a primary care residency, or a psychiatrist. But those are by far the minority. Majority of patient or physicians who get involved are anesthesiologists or physical medicine rehabilitation docs. And as I was saying, after 2004, after you finish your residency in one of those areas, you had to do a one-year fellowship. And then in order to become board certified following the fellowship, you had to sit and pass a written examination. And actually, we have to maintain that by retaking the test every 10 years, which I did last year, which is always fun. As far as referrals go, I always tell primary care physicians if it hurts, refer it. We are neuromusculoskeletal specialists. We specializes in all types of pain. It doesn't have to be, a lot of times people think that it's just got to be spine pain, that I can't deal with joint pain, but no, if it hurts, send it over. Our goal as a pain specialist, usually at that initial consultation, is to thoroughly evaluate that patient, apply the biopsychosocial model, see, is this a pain issue? Is this a pill issue? Is this, they got ongoing stressors that are making matters worse? And then try to treat that patient according to what you're seeing at that initial consultation? Can you just address the pain? Do you need to address psychiatric or psychological issues? Do you need to, get the family involved? Is there a lot of social things going on that's making this patient worse? And you just can't put, not everybody's a round peg that's going to fit in a round hole. You need to treat the patient according to their special situation.
Sounds good. Any questions for Dr. Patterson? So is Dr. Cole a psychiatrist?
Yes.
Doc-
And neurologist.
And neurologist. Dr. Cole.
And an anesthesia pain fellowship trained pain specialist. So I have 3 areas.
All right, yep. Tell us how can we
I just want to remind everybody that before anesthesia inserted itself into pain medicine, pain management, this was a field really created by clinical psychology and, of all things, neurosurgery. So in the 70s, you're talking about a profession that was terribly cerebral. And then by the 80s, neurology, psychiatry sort of started to creep in. And it was really into the 90s where anesthesia comes in. And by the 2000s, physical medicine rehab. And now you really don't find any psychiatrists, any neurosurgeons. But the original 4 boards or 4 eligible groups for board certification have always been in order. First, anesthesia, because they continued to try and work on this when everybody else got up and walked away from the table in the late 90s. And then we got an invitation for the PM&R community. And then the last group that kind of came back to the table, curiously, was the American Board of Psychiatry and Neurology. Now, what's been interesting is that rheumatologists have been able to slip in clandestinely by claiming that they're derivatives or, somehow linked into PM&R. So I know some rheumatologists who got their boards by going through the American Board of Physical Med and Rehab. But it's interesting that the evolution of the field has moved away from the brain kind of down into anesthesia. So the psychologists and the neurosurgeons are much less represented today than when I entered the field in '85 and was, still talking with the original founders of the field who had created the IASP, who created the APS. You were talking about nothing but neurosurgeons and psychologists. Anyway, it's been an interesting evolution.
Yeah.
Wow, things keep on a-changing. Yep. Thank you very much. It's always always wonderful having you. One of the things that I was looking at when I was looking at the different specialties was where do we refer? What do we do? How do we refer? And so I was looking into what does a social worker do? Well, social workers a lot of times bring people together. They know the referral sources. And one of the websites I'd like to leave you with is healthierNV.org. It's acknowledged by the governor and attorney general. They both endorse this. So healthierNV.org, and that can give you insights as to what's available in the community when it comes to treatment or any kind of mental health kind of referral that you might need. And it's it's pretty thorough, and it has good resources on there. So thank you very much, everyone, for being here. Always Dr. Lewandowski and Dr. Patterson, always brilliant having you here. And next one is, what are we doing next time?
Motivational interviewing, and I think it's October the 3rd.
Yes, sir. October 3rd, we're going to have Dr. Lewandowski motivational interviewing.
You don't want to miss that one. Okay. Thank you all very much.